All right, up to you.
All right. Hi, everyone. So today we have Dr. Chu with us, and you can take it away with like an introduction and then with your case.
Right, so yeah, I'll go through with the introduction. So anyway, so you see my bio, but basically I'm a rheumatologist. I'm also a researcher. So I'm seeing patients in OHSU and also at the VA medical center here. I have a lab in the VA building. That's where I'm sitting right now. Maybe I can know each of you a little bit better. Can you give me like a 1 or 2 sentences of introduction, please?
My name is Eileen. I'm a junior at Bakersfield High School.
Thank you.
So I'm Renee, and I am a sophomore at Lake Oswego High School.
I'm Kyla, and I'm also a junior at Lake Oswego High School.
All right. So you guys all want to go to medical school? Is that what you, at least right now, you think of going to medical school, right? Okay. And Andrew, I heard you are teaching at PCC. You're teaching biology?
Yeah, so I teach A&P at Portland Community College.
Mm-hmm. And Miss
I used to
Lloyd?
teach more stuff, but there's a huge demand for A&P instructors, and so I've stopped teaching intro bio and cell, and just all I do now is A&P. That's the big demand.
I see. All right.
Yeah.
My name is Wei Wei Lo. I work with the kids. We wrote a grant which is paying for this course.
All right, great.
Right.
Thank you for helping the kids. Yeah, great. All right, so let's get going, and let me share my slide. So I think. So I heard, so this is going to be like an informal kind of a teaching discussion, and I will do that way. So I talked a little bit about myself. So basically, the official name, you call this a physician scientist for myself. So what's a physician scientist? Basically, is a physician doing research at the same time as well seeing patients. So it can be an MD itself, does not need to be a PhD, but for myself, I have MD and a PhD, which I obtained in a different way in comparison with most of the American medical graduates. So I got my MD from medical school in China and PhD in London, UK, University of London, after a couple of years of residency in Beijing. So then I came to the United States, regained the training in residencies and fellowships, and came to Poland, where I am as a faculty in the division of arthritis and rheumatic diseases, or in other words, rheumatology. So a physician scientist, as I said, it's really depending on how much you prefer and how much you're in demand. You can divide yourself into half and half, means half of the time you are taking care of patients, and the other half doing research. The patient care can be like rheumatology is most of them outpatient-based settings, but we do see patient when they are hospitalized. We call it inpatient consult. I can explain to you guys a little bit more about that. And the other half, as I said, research. The research can be clinical research or translational or basic science. So it's really depending on your training background and your personal interest. So I don't know how much you guys aware about some difference between clinical, translational, or basic science, but I can give you a little bit introduction about that. So basic science traditionally is like a bench-based research. You're setting basic research by doing research in the lab. Really, you can be like a chemical or chemistry-based or immunology-based or biochemistry, pure biology, whatever, or anatomy. So whatever the interest you have, like, or pharmacology. So basically, it can be wide range of different disciplines. The translational is kind of a name given recent years to those research can be translated into practical applications. So it's in between the clinical research and the basic research. So say, for example, if you invented something in the lab, which can be further developed into a drug, for example. So that's kind of or one of the examples of translational research. So clinical research will be mostly based on patients. You do research based on patient samples or patient clinical features. And say, for example, you want to see the outcome of rheumatoid arthritis patient being treated with some of the medications, and you want to study their clinical features and so on. Yeah, if you have any questions, just let me know, okay? So what is a rheumatologist? You're probably less familiar with this subspecialty. So rheumatology itself is a subspecialty of internal medicine. You might be more familiar with like cardiology, gastroenterology type of thing, but rheumatology is not based on the I would say anatomy type of like a specialty. So a rheumatologist seeing patient with rheumatic diseases, but even you hear this word, it still doesn't make any sense. So what's a rheumatic disease? It covers a lot different variety of conditions. So traditionally including musculoskeletal diseases and systemic so-called autoimmune conditions. It covers a whole range of different conditions. As I said, it's not like based on anatomy or organ system. And for example, we can have, I'll show you an example later in the case. For example, a patient with lupus can affect all organ systems. So we all have to deal with that. So some of the rheumatology will focus on some of the different aspects. And for example, I'm interested in immunology. So I am interested in patients with immune-mediated conditions. So for example, rheumatoid arthritis and lupus are the immune-mediated condition, also called autoimmune diseases. So basically, rheumatologist is an internist, or traditionally we divided doctors as physicians versus surgeons. So physicians do not do procedures. In other words, they do not operate or doing surgeries, but surgeons will primarily treat patients with surgical procedures. So that's the important difference. All right. Any questions so far? So I hope if I can go over what these two cases, and then we spent the next hour on Friday talking about the autoimmunity and the other things. I think those are quite interesting thing to learn. So let's go on with the case one. So this is a 45-year-old woman and presented to your office with complaints of joint pain and stiffness in hands primarily and also in wrist. And the pain is moderate if we use the visual analog scales. She counted like a 6.5 versus over total 10. And this has been going on for 5 months. They're not in remission or resolving. And the morning stiffness, we counted, or the patient counted as probably greater than 1 hour each day, and can go long, whole day or at least half day of that. And the patient is current smoker. She has a family history of rheumatoid arthritis, being her mother had rheumatoid arthritis. So this is a patient with rheumatoid arthritis. So I'm not going to trick you with any question at this point. So I just want to introduce this case straight away from now. So by the examination, as you can see in the photograph showing, we call synovitis, means the swelling of the joint which reflects inflammation of the soft tissue or called lining in the joint. In we call it PIP joint, proximal interphalangeal joint, and the metacarpal joint, or we call it MCP joint. So these are the MCP, and this called PIP joint. So something is quite interesting for rheumatoid arthritis. So this is called a PIP joint, and this is called a DIP joint, distal interphalangeal joint. And for some specific reason we never understand it, this joint got involved, but not this joint. So if you look at structure and anatomy, this joint and this joint are almost the same, but why they're only affecting the PIP joint but not the DIP joint? So this is a very interesting question, but have been puzzled us for many years, and nobody knows answers for that yet. So if you guys wanted to solve the problem, or you solve the problem, that'd be great. Okay. So as doctors, we always wanted to do some blood tests, and here are the 2 tests we run currently for rheumatoid arthritis. The first one called, you might hear some word called anti-CCP, which stands for cyclic citrullinated peptide, or it called ACPA, is anti-citrullinated protein antibodies. So this is a protein and changed the nature by some process. I can show you later about that. And your body produces antibodies against them. And they turn out to be very specific for rheumatoid arthritis. As I put on here, the specificity is greater than 95% for rheumatoid arthritis. And you might have heard, or you will hear if you get into the medical field, for rheumatoid factor, which was first found to be in a patient with rheumatoid arthritis. That's why this factor coming from. So the specificity actually is not as good as the ACPA antibody. It's only about 80%. So this is the autoantibody against host immunoglobulin G, or IgG. Okay, and we often also want to detect or measure the inflammation levels of the patient by doing a blood test. One of this protein called C-reactive protein, which is produced by the liver and is in response to inflammation. the inflammation can be anything, any factor cause inflammation. Can be by virus infection, like COVID infection, adenovirus, flu, or bacterial fungal infections, or these autoimmune inflammation, like in this case, rheumatoid arthritis. So this is not specific, but it's a marker for inflammation. It simply reflects your body has inflammation. So this is a more advanced disease in rheumatoid arthritis, as you can see in progress, and the joint in the MCP get more inflamed, and the joint gets destroyed and become deformed, like this one. This way, you see the fingers deviated into the lateral side, which we call ulnar deviation. That's based on the anatomy of this bones in the forearm. This side, there's a this bone called ulnar, and so that's why it's called ulnar deviation to that. And you probably noticed, so the PIP joint, this particular photos are not so much involved as compared with the MCP joint. So this is just brief introduction about rheumatoid arthritis. So rheumatoid arthritis is pretty common disease, but not as common as like other diseases like hypertension, diabetes, but it does affect up to like 1% of the population worldwide. As in other autoimmune diseases, the female is affected more than the males. The ratio about 3 to 1. I show you the inflammation is in the joint, but as a matter of fact, rheumatoid arthritis is a disease affecting the whole system, the whole body. That's why we call it systemic inflammation. And this disease does cause a lot of disability, not only because of the joint gets damaged, but also the systemic inflammation can put patient into risk for developing cardiovascular diseases that can even cause the premature death if you leave the patient untreated. So this line or graph just showing you the natural cause of rheumatoid arthritis. So if the patient develops rheumatoid arthritis left untreated, with the time, almost like every single patient will become disabled. It's a chronic disease. It can take like many years and decades to get into that. But some of the patients can progress even a little bit faster than that. All right. So we see rheumatoid arthritis by seeing the patients through their joints, through their skin. And the other way to assess the severity of rheumatoid arthritis is by doing the imaging studies, as you can see here, by the X-ray. So here are the MCP joint, as you can see here. Even a patient have the so-called synovitis, but they do not necessarily have to have the destruction of the bones. So the bone and cartilage destruction is really severe and more advanced disease. But in comparison on this graph, you can see the deformed MCP joint. This is almost like the same joint you see in the previous slide, showing the hand with ulnar deviation. I can go back to slides, show you that, so you can have some more impression like this one, right? So if you put X-ray here, and you can see the picture like that. So there's some other ways to view or assess the severity of rheumatoid arthritis. As you can see here, we call it arthroscopy. So it means you insert a camera into the joint, and then you can view the structure within the joint. So this is a normal joint, look like pretty smooth of the surface of the cartilage, with something we call the synovium, is again the very thin layers of soft tissue lining the surface of the joint. So in rheumatoid arthritis, this is the early stage of that. You can see the inflammation going on already here, with some new vessels formed. And if you look at the next slide, I'm going to show you, because of the cell accumulate into the joint, and that's showing of the inflammation here. And this is at a peak of the inflammation. You can see the growth of the synovium and forming some kind of tumor-like tissues here. And this is the most advanced rheumatoid arthritis you can see by the arthroscopy. And you can see the normal structure cannot be visualized, but instead the joint get kind of destroyed. Now you can imagine how the function will be affected by this rheumatoid arthritis. So let's go another layer deeper into the rheumatoid arthritis. This under microscope, what you see here is, so this picture is from a mouse, and it's hard to include a big joint in humans into one small picture like this. But this is just illustrates the structure of the joint. What you can see here, this is the surface of the cartilage, and underneath this is called subchondral bone. And then you go further deeper, you get into the bone marrow. And again, this is the so-called synovium or synovial tissue. As you can see here, there's not many cells you can see. And again, this is amplified. You can see a few cell layers in the lining of the synovium. But the picture in rheumatoid synovium is completely different. What you can see here with massive infiltrate or accumulation of cells here. So in those areas, as amplified here, they're forming like a mass, or we call it follicles. And is this kind of a structure you will see in the lymphoid tissue. So in other words, and sometimes we refer this called ectopic lymphoid tissue formation in rheumatoid arthritis. Means those lymphocytes are not supposed to be here in the normal joint, but in rheumatoid, for some reason, they get accumulated here, causing the persistent inflammation. And here is another example showing the expansion of the synovium compared with this only 1 or 2 layers of cells. If you look at it carefully, there's more than like 5 or 6 layers of cells. It's a massive expansion of that. And in some area, you can see this synovium, just like those tissue, can grow directly into the cartilage. So here is the cartilage, and this is the inflamed synovium getting to the invade into the cartilage and the subchondral bone. So this is an area causing the destruction of the joint. So let's go on to look at the rheumatoid arthritis in a cellular level. Again, this is a synovium taken from a patient with rheumatoid arthritis. I think this is from a biopsy. which you can use the same instrument like the arthroscope and have a forceps insert into the joint and take a piece of the synovium, as you can see in those ones. Then you cut into thin sections or thin layers of tissue and view it under microscope. And so this one showing you, this is technology called immunohistochemistry. I'm going to introduce you to that later. And stain a cell marker called CD3, which expressed on T lymphocytes. If you guys have heard some about immunology, T cells or T lymphocytes versus B lymphocytes, you may have heard about that because of the COVID pandemic. The vaccines will, stimulate T cells and B cells and make them produce antibodies. So these are the similar concept. This is a T lymphocyte got infiltrated into the synovium of the rheumatoid patient, but causing inflammation here. And this is CD20 staining showing the B lymphocytes. So this could be in the same areas, but you have to separate by different, pictures showing the different staining. But with some advanced technology, you can show the T cells and B cells in the same slides, but showing the different color, for example. And again, I'm going to show you later about B cells becoming plasma cells. So the B cells can differentiate into plasma cells then producing antibodies. So we'll talk a little bit more about that later when we talk about immunology. And this slide showing you a different cell type called macrophages, which been identified by this marker called CD68. So in summary, in the rheumatoid synovium, you can have the accumulation of the immune cells or inflammatory cells, including T cells, B cells, and macrophages here. But those are the main cells, and there's some other cells there too. And one of another important cell type I did not mention is called fibroblasts. Fibroblasts are the cells not considered to be immune cells. So I'm not going to talk more about that at this time. Then we can move on to the next level of rheumatoid arthritis. So it's called molecular level to assess rheumatoid arthritis. So again, using the similar technology, immunohistochemistry, with antibody against this molecule, or we call it cytokine. The name is tumor necrosis factor, so this slide showing those are my own work when I was doing my PhD studies. Actually, we found that the TNF is overexpressed in rheumatoid arthritis, and currently there are 5 medications, or it's called biologic medications, have been developed for treating rheumatoid arthritis. They are very potent and they can put patient into remission. So these green cells identify as TNF expressing cells. So in other words, they produce TNF, and at the same time, they can bind to the TNF receptors in the same areas of the synovium. And this amplified region, which I showed you earlier, where the synovium grow into the cartilage. The C areas is a cartilage, and the P called the pannus. Why it's called pannus? Because this tissue have increased number of vessels. That's named pannus. the synovium, because inflammation and blood vessel formation, they get embedded into the cartilage. So those are the areas and the cells producing a lot of TNF. So TNF then bind to the TNF receptors and causing the damage to the cartilage. So I mentioned a little bit early about the therapy based on the findings in the immunohistochemistry. And so in addition to TNF, other cytokine, or we call it pro-inflammatory cytokines, they all can cause inflammation in the rheumatoid arthritis. So there are 2 monoclonal antibodies against IL-6 or interleukin-6 receptors, and they are potent medications. They are monoclonal antibodies. I'm going to go over more about all the monoclonal antibodies later. And there's also interleukin-1, another inflammatory cytokine, and there's a recombinant version. It's a like a man-made or bioengineering technology made a molecule called interleukin-1 receptor antagonist. It can block the activity of IL-1. And so I mentioned about TNF inhibitors. There are 4 monoclonal antibodies against TNF and 1 called soluble receptor. What it means here is you have the extracellular domain of the TNF receptor, which is the part of the molecule combined to the ligand, here it's a TNF, which can block this TNF to bind to the receptor on the cell surface. So to block the TNF activity onto the cells. All right, so are you guys familiar with cytokines? So basically, cytokines are proteins or called glycoproteins. They are secreted by cells, then work on different cell types or act on their own cells. So with all different mechanisms of actions. So Kyla, you raise your hand. Sounds like you either have a question, you know the answers about cytokines.
Oh, my hand was raised for like a couple slides ago. Like on the slide it said, like I think it was arthritis was more common in women. Like, is there like a reason for that? Is it because like
that's good point. So there's a lot of theories, but you know, could be because of chromosomes, could be because the sex hormones like estrogens. There's a lot of studies in that part, but still there's no definitive answer for that. But that's really the phenomenon we have. And I have slides later to show you in different autoimmune diseases.
Oh, thank you.
All right. All right, if you guys okay with that, so we can carry on with this. Yeah, so for rheumatoid arthritis, there are some other therapeutic targets. So we mentioned about T cells because they are in large number there and they are active, causing the inflammation and damage to the joint. So we have developed a treatment for that. It's called abatacept, and it's blocking the T cell activation. Okay, so the T cells and other immune cells need to be activated before they can really take effect. So that's why you block the T cell activation will be effective for treating the disease like that. And so here is another one called B cell targeted therapy with a monoclonal antibody called rituximab. is the antibody directly against CD20. And as you can see here, CD20 is a marker for B cells. So they can kill the B cells in this case. All right. So I mentioned about citrinylation or citrinylated protein. So if you study biochemistry, you might have heard this word arginine, right? So this is one of the amino acid which can be part of the peptide or protein. So it turned out to be that arginine carry very high positive charges. But with this enzyme digestion activities, you can change the arginine into citrulline, which carries neutral positive charges. What happened is once the protein becomes neutral, it makes it easier to be bound by the T cell receptors. So the T cell have surface receptors can bind to some peptide or proteins, and then can present it to antigen presenting cells. Sorry, it's another way around. So the protein or peptides can bind to the T cell receptor in the contact with we call it MRC, major histocompatibility complex. So this is a little bit too complex to explain in the immune response. So in order for an immune response, for example, T cell response happen, you need 3 components. You have the so-called antigen presenting cells and a T cell and a antigen. So antigen in this case with peptide. So when the arginine becomes citrulline, the protein becomes neutral, and it's not been expelled by the positive charges like protein in the T cell receptor or the MRC. So that makes them easier to bind together. All right. So then your body will make antibody against the protein. So I think I'll try to go through the case 2, then we'll leave the whole hour discussion on Friday. Then we can go through some basic immunology and some of the antibodies. I think that's even more interesting to discuss too. All right. So case 2 is a lupus, as I indicated in the email. So this is a 25-year-old female and presented with pain in the joint with, you're familiar with this word called synovitis, means like a swelling in the joint over the similar joint distribution like MCP and PIP joints, okay? But the features in this lady different from the previous woman is she has profound rashes on the face. So this is called a malar rash in the malar areas of the rash. And the patient also have rashes in the leg and the trunk. She also has another feature called recurrent oral ulcers. So this ulcers in the oral mucosal membrane is recurrent. It can come and heal and come again. So, and patient also complains of a fatigue with low energy and doesn't have any like strength to a lot of different things. And the patient also complains of chest pain on breathing. It's called pleurisy. Means the lining of the lungs gets inflamed when you take breath. When the lung gets expanded, it can get stimulated to the pleural and cause some pain. That's called pleurisy. So the rashes can be mild like this one, or can be more severe like the previous one, and can be even more severe than the previous one. I'll show you in next few slides. So again, we'll do lab tests showing the WBC, white blood cells or leukocyte. The count is slightly lower than the normal range. The normal range will be like a 4 to 10. Here is slightly lowered, and platelets much decreased. Number of platelets much decreased. So at least the normal range should be greater than 100. Okay, so this is some of the features of lupus can causing the problem. Here, another concept to introduce to you called erythrocyte sedimentation rate, or called ESR, or in other words called SED rate. It's 33. Normally in this range of population will be less than 30. So that's another indicator for inflammation in the body. And when we do urine analysis, and it shows she has 3+ protein. This is a semi-quantitative measure of the protein levels. So normally in urine, you are not supposed to detect any protein. So if the protein present in the urine, and normally that means you have some problem with the kidneys. So the kidney gets damaged and they are leaking the protein to that. And the other important lab test called antinuclear antibody test, or ANA, showing very positive. This is the expression is 1 to 640. What that means here is you dilute the serum from the patient and 640 times. So once you do an assay, you wanted to see, so this is another way to quantify the amount of the antibodies. So the further dilution means the higher concentration of these autoantibodies in there. Okay, Kyla, you have a question?
Yeah, so for these autoimmune diseases like lupus and arthritis, is it like in your genetics, or is there some outside factor that like activates it, or is it like a combination of both?
It's a combination. So this is, we call the polygenetic condition. It's not like, I don't know if you guys are familiar with the cystic fibrosis. So that's just one gene mutation can cause the disease. But in lupus or rheumatoid arthritis and many of the autoimmune diseases, you can find a lot genes either mutated or have variations from the normal. So they all like work in the way which we still don't understand it, might work together, or each of the genes has slightly, small role in the autoimmunity, but all together get, a combination can trigger the autoimmune condition. But if you only have those genetics, doesn't mean you always get this autoimmune disease develop. So the environmental factors are very important too to trigger or initiate the genetic problems. I mentioned in the first case, she was a smoker. So smoking has been associated with development of rheumatoid arthritis.
So is there like a specific gene that you have to get activated, or can a person who like doesn't have the gene get like lupus or rheumatoid arthritis?
It's not clear how this, initiated, but certainly what we have known so far, all those factors can be associated with that. So it's not like a cause effect, clear pathways have been identified. So lupus could be initiated by infection. So there's a lot of theories in that, but still, it's very hard to confirm those.
All right.
And autoimmune disease are very complicated. All right, so this again, another statistics. So lupus is much less common than rheumatoid arthritis, but it's really a disease manifesting a lot of features for autoimmune diseases. And we do see a lot of such patients. But again, in comparison with the rheumatoid arthritis, much less common. So in the United States, what you most see the patient get affected are African Americans, Hispanics, and Asian, and then Caucasians. But the cases I present to you are all Caucasians. Anyway, so but those are the samples I have. Anyway, here the female dominant phenomenon here even much more than rheumatoid arthritis. This is about 8-to-1. And as a case shown was 25 here, so the range would be 15 to 64. All we can see is like a childbearing age of women get affected. And we are not doing so well for treating lupus in comparison with treating rheumatoid arthritis. So the choices for treating lupus medically is quite limited. So as I mentioned, there's more severe skin rashes. This is called lupus and skin rashes. Sometimes they call it discoid lupus because the shape of the rashes, they can really forming scars in those skin with rashes. And these are the other interesting and important features for lupus. And as you can see here, so the rashes are really in the sun exposure or light exposure areas. So once it's covered by clothes and is not affected. So, and it's certainly something to do with some light, like UV light in the sunlight. And here is another example of that. All right, so Kyla, you have a question?
Yeah, so like just like rheumatoid arthritis, is the reason why lupus is more common in women is because of like the sex hormones, or is there like another reason?
Yeah, so that's so far we know about that. Probably more to do with the estrogen, yeah, so this is, again, this phenomenon we have found about, we really haven't got really a definitive answer for that. So lupus, again, is another systemic disease. As I mentioned earlier, can affect the whole body, any of the organ system, from the scalp, the hairs, and oftentimes patient complains of hair loss or alopecia. And we mentioned about the photosensitivity, the skin get rashes. And this is the heart, they can affect the valve, can affect the pericardium, means the sac of the sac surrounding the heart, pericardium. So this is inflammation. can cause inflammation in the lung and the lining of the lung. I mentioned about pleurisy, so they can affect the blood system, affecting the immune component, as we demonstrated that with lower numbers of white blood cells and platelets. So, for example, and patient can also present with anemia as well, and they can affect kidney, which I have slides show you what's it look like, and affect the joint and the muscles as we presented by the patient. So ulcers in the mouth, mucosal membrane. And so this is the so-called lupus nephritis. So it is the inflammation of the kidney. So this is the unit of called glomerula. It's the unit you are filtering the blood and filter out the toxic component, then express that into the urine. So you need some space and cells for them to work. But in this case, in lupus nephritis, you can see a lot of inflammation going on. The normal structure of the glomerula gets destroyed. So that's why the patient can present with inflammation and have the protein in urine. And this is the so-called, I believe this is red blood cell cast. Means the patient can have leaking of blood into the urine, and when they go through the structure of the filters, then they accumulate together, forming a mass of red blood cells. And this is another example of immunohistochemistry. In this way, you have the fluorescence to indicate the positive finding. Here you show the ITT, and it's ITT bind to one of the antigens, because the molecules is huge, cannot be filtered out, and but they just get left over in the kidney. Then you use the immunohistochemistry to detect it. So again, this large amount of the proteins get into the kidney. It's kind of like a plug the kidney, and they are not be able to filter the blood. So it's 1:07. I think we can stop here. And I have about 10 slides. We can leave to the next hour for discussion. Yeah, the next slide will be talking about the autoantibodies, and then we can just follow that line, talk about antibodies, autoantibodies, autoimmunity, and type of things. All
Sorry, I
right.
have a quick question about.
Yeah.
So, on one of your slides, when you're talking about lupus and like the common like side effects or like general effects on the patient, I noticed that there's like a part around the brain that talks about how there can be cognitive dysfunction. Do you know like how often or like how severe these kinds of dysfunctions usually are?
Yeah, so the severity varies. Like you mentioned, it can have cognitive impairments, like they cannot study well. That can be the first experience by the patient, and often it's hard to detect, and people just feel you are tired, you are not really focused. But the problem is, and the patient cannot focus on themselves. It's not really they don't like study. They wanted to, but they are not able to. And they can have psychosis, means they can have psychiatric expression for that. also more severe, they can have a something like a seizure. So that's really is the inflammation in the brain, in the regions, depending on which areas get affected. They have different manifestations. Did that answer your question?
Yeah, thank you.
All right. Okay, before we leave, any more questions about the cases? So since we have a few more days to go, you can go on back to read about those cases and see any related questions you can think of. I sent the slide to you guys. You can really look at the slide and see what question you have in mind, and we can discuss all together next week and Friday.
That sounds good. Thank you.
All right.
Thank you so much.
Thank you.
Yeah, thanks.
All right. So we'll see you on Friday, same time. Bye.